As anticipated, we have heard a very excellent review on the role of neoadjuvant chemotherapy by David Cunningham. He really made the best out of it, but in my talk, I will show you that we should prefer chemoradiation prior to surgery. And I will focus on three main reasons for that. First is chemoradiation is best able to increase the chance for complete tumor resection. Second one, it's increasing the downstaging to tumor-free lymph nodes. And the third one, it's increasing chance for reaching a major histologic tumor regression. All these issues are factors that predict for long-term survival, and beside that, chemoradiation does not increase operative mortality. What we all know is that surgery alone is not able to cure our patients. That's data from the world-leading centers in esophageal surgery, and what we talk about, stage 2, stage 3 adenocarcinomas, the minority of the patients will be cured by surgery alone. So we will focus on perioperative treatments to improve the prognosis, and we have a lot of meta-analysis who prove that this is possible. The recent one, a nice Cochrane analysis, showed us by including individual patient data that we have about a 20% increase or a decrease in tumor-related mortality when we treat the patients prior to surgery. But what is interesting from this meta-analysis is that this benefit by preoperative treatment is increasing with the tumor extent, and this benefit is much more enlarged by chemoradiation, hazard ratio of 1.7, than by chemotherapy alone prior to surgery, hazard ratio 1.8. So I think we should prefer chemoradiation. There is some concern that including radiotherapy in the preoperative concept may increase the rate of postoperative death. There are indeed some meta-analyses which show a small increase of this risk, but this increased risk of postoperative mortality is limited to patients with squamous cell carcinoma, whereas the 30-day or postoperative mortality is almost identical in patients with esophageal adenocarcinomas. So what about randomized data? We have 2 trials published comparing preoperative chemoradiation with preoperative chemotherapy alone. One was the larger German trial in locally advanced tumors, including 126 patients, and the other was an Australian trial, a randomized phase 2 trial, including only 75 patients in somewhat less extended tumors. What are the results? First of all, the German trial did not reach or meet its primary objective, although the p-value of overall survival was 1.07. But I think a 20% increase in 3-year survival is clinically relevant. The second trial met its primary objective. The phase 2 trial from Australia was able to show that the complete tumor regression rate is increased from 0 to 13% by chemoradiation compared to chemotherapy alone. So we have a lot of hints for the superiority of chemoradiation. What are the causes, the reasons for that? First of all, it's able to increase the RO resection rate. That's shown by these two, by sub-analysis of these 2 randomized trials. In the German as well as in the Australian trial, in both trials, incomplete resections were lower than, after chemoradiation, 4 or 0%, compared to after chemotherapy, 15 or 11%. And what we know is that incomplete resection is an important negative prognostic factor. This has been shown nicely from this very recent publication from the British pathologists, where we can see that a close circumferential resection margin is a negative prognostic factor. But moreover, what we know from British data is that the proximity to the tumor, to the circumferential resection margin, the role of this proximity is different between different treatment strategies. After surgery or chemotherapy with surgery, it's very important. Close resection, or small resection margin means poor prognosis, but this is not significant in chemoradiotherapy patients followed by surgery. Even then, the rate of incomplete resection goes down by chemoradiation, but even for those patients with R1 resection, the importance of this R1 resection is obviously not significantly important. And what we also know from British data is the results of the OEO2 trial comparing preoperative chemotherapy with surgery alone. Again, we know the smaller the distance from the circumferential resection margin, the poorer the prognosis for the people. But what's important, these poor prognosis cannot, or post-operative radiotherapy or chemoradiotherapy cannot compensate for these poor surgical results. So we should use it prior to surgery. And the last one, second hypothesis is chemoradiation is better able to downstage to tumor-free lymph nodes. That's important. We know that from primary surgery. The number of involved lymph nodes at surgery predicts the rate of systemic recurrences. Here in the international cooperative group data, tumor-free lymph node means recurrence rate, systemic recurrence rate of about 15%, and an P2 stage, for example, then the systemic recurrence risk increased to 75%. This was also seen in our trial with preoperative chemo or chemoradiotherapy. Patients with tumor-free lymph nodes after induction treatment have a significant better prognosis than patients with still positive lymph nodes. And the chance for getting these lymph nodes tumor-free is significantly improved by chemoradiation compared to preoperative chemotherapy alone. This has been shown in our POET subgroup analysis. The last argument for the chemoradiation is that it is able, or in more patients, able to find definitive histologic tumor remission. Many data have shown that this is important. This is data from the Memorial Sloan Kettering Cancer Center and in adenocarcinomas, esophageal adenocarcinomas, and as you see in the yellow line, the recurrence rate at 3 years is significantly lower when the patients have reached a PCR, a pathologic complete remission after chemoradiation, compared to other patients with R0 resection. And this is true although the treatment did not change the localization of recurrences. We have also seen that in the POET trial, patients with a complete pathologic complete remission have an excellent long-term prognosis, whereas other patients with R0 resection did poorer, although long-term survival of almost 50% is not bad. The chance for getting complete tumor resection is improving when using chemoradiation compared to chemotherapy alone. That has been shown in our trial, increased from 2 to almost 16%, and also in the randomized Australian trial from increases from 0 to 13%. So overall, my conclusion is, although we don't have a formal, sufficiently large phase 3 trial, we should prefer chemoradiotherapy prior to surgery compared to neoadjuvant chemotherapy because this reflects today the optimal therapy for the patients, and the superiority is achieved by increasing the chance of complete tumor resection, by increasing downstaging to PN0 category, and by increasing the chance of reaching major histologic tumor regression. And these achievements have not been reached at the cost of increased operative mortality. Thank you for your attention.